basically start diving a little bit more into evidence-based practice. Okay, we've introduced this topic and we've talked about it some in class, but what I want to do today is I want to take the time to start really kind of discussing this in depth. Okay, so let me go ahead and share my screen, and we'll get rolling. There it is. Perfect. Up here. All right. So, guys, can you see my screen? Yeah.
Yep.
Awesome. Thank you so much. Okay. So before we get started, okay, we introduced on Monday, we talked about kind of an introduction to what evidence-based practice is. Okay. What do you remember about what are some of the basics of evidence-based practice? What does that mean and how do we define it? What can you remember from Monday? And I've got my screen maximized so I can't see anybody if you raise your hand. So if you go ahead and shout it out. What do you remember about evidence-based practice from Monday? What's one thing that pops into your head?
Using credible sources by reliable authors.
Bingo. Absolutely. Okay. That's definitely one aspect of it. Okay. How many of you guys think, and this is something that we'll talk about a little bit more. How many of you guys think though that obviously, well, that's a big part, right? There's obvious components to EBP that involve the clinician using their experience, right? And also kind of utilizing obviously also patient characteristics. Would you guys agree with that statement or would you disagree with that statement?
I'm sorry, can you repeat that again?
Absolutely. Yes. So for evidence-based practice, right? We said, obviously, yes, it's about finding the best possible evidence, but do you think it's also true, right, that if we're going to utilize evidence-based practice, that also involves using the clinician's experience, right, and the patient's circumstances in making that decision or determining what the best evidence is in that case?
I think it's important because obviously each person is unique, but you have to base it off of something. Like you're not just gonna randomly pick like a treatment or an intervention,
Yep.
but you do have to like adapt that to your unique like client.
Absolutely. Absolutely. Right. So the bottom line, guys, and great. Yeah, I like that. Great response. Okay. So the bottom line is that evidence-based practice obviously involves the use of the best available evidence, like we've talked about. And we're going to talk about, to a degree, some of the rigor involved today, and that's kind of what we're going to be talking about over the next week or so, next week or two, right? The rigor in selecting the most appropriate research, but at the same time, we're also going to kind of start to notice and learn, right, that it's also our responsibility to take the evidence and apply it to the patient. At least as it applies to their situation clinically, right? And also utilization of our um, of our experience, right? And what we know to be true and effective as clinicians. So here's an example. Okay, let's say that there's a doctor, and we'll go through this slide that we have in front of us here in a second. But I want to kind of continue to set the stage here. Okay, let me give you an example. Let's say that we have come that within the past maybe 6 months to a year, there is a brand new treatment, a brand new surgical method, right, for ACL reconstruction in the knee that looks to be super, super promising and has, basically superior characteristics in regards to, the strength of the graft that's being used and outcomes. And patients are doing really, really well with this new surgical approach to ACL reconstruction, right? Do you think that, you know, despite the fact that we have, emerging evidence that agrees, and it's been replicated over and over again that this is effective, do you think that it would be responsible and wise for a clinician to endorse a surgery, a new surgical intervention or approach that they have not practiced themselves? If you need me to rephrase the question, let me know.
I think they could maybe like recommend it, but more as like a referral. So they could like say that
Yeah,
they've heard about it and other doctors are doing it, but not like to do it themselves since they haven't done it.
absolutely fantastic, right? So let's say, for example, okay, let's say maybe a year or two later, right? A lot of the evidence, a lot of the scientific studies are still saying the exact same thing. But now, okay, that same physician, that same doctor, um, has had some time where they've actually learned with other physicians, and they've utilized this technique for for a period of time, 6 months to a year, and they've become pretty pretty comfortable with it, utilizing it in the operating room clinically, right? And things appear to be going well. Obviously, then we could be confident that the clinician could obviously, pardon me, make that recommendation, excuse me, make the recommendation and have much more confidence in their ability that that would be successful for their patients. Now, also based on their clinical experiences. Okay, so as we'll talk about in a second, evidence-based practice, yes, does involve the use of the best available evidence, but the clinician's experience and also the patient individual patient circumstances have to be considered in how we utilize that evidence, right? So evidence-based practice is a combination of those three things. Okay, and for those of you that like kind of formal definitions, there are more than one, but this is the one that is currently utilized in our textbook for this course, right? So it says that EBP has been defined as a paradigm and a lifelong problem-solving approach to clinical decision making, okay, that involves the conscientious use of the best available evidence, okay, including systematic search for and critical appraisal of the most relevant evidence to answer a question, okay, that with one's own clinical expertise and patient values and preferences to improve outcomes for individuals, communities, and systems, right? So obviously, once again, the goal, right, the overall purpose of evidence-based practice is to provide good patient outcomes, right, and provide care that is not only efficient but that benefits the patient and even larger populations, communities, and healthcare systems as a whole. Okay, healthcare systems as a whole. So another thing that, and we'll talk more about this as well, but kind of a sister concept, if you will, to evidence-based practice is something called patient-centered care. Okay, so patient-centered care is providing care that's respectful and responsive to individual patient preferences, needs, and values, right? And ensuring that patient values guide all clinical decisions. Okay, so it's really, really important, obviously, to make those evidence-based practice decisions, right? Utilizing the evidence, utilizing the clinician's experience and the patient's individual circumstances, right? But then we have to take that decision and tailor that decision and our recommendations, obviously, to the patient, right? Based on the patient's preferences, based on their values. And we'll give you an example of that here in a second. All right, that's my cat, if you can hear that. Animals are being ridiculous today. So, okay. So, guys, EBP, evidence-based practice, has really been kind of thought of and known as a three-legged stool. Okay, as we've said now, right? We have to keep in mind, obviously, what is the best evidence, right? What are the patient's circumstances in this case, and then what is the clinician's expertise and experience with applying that evidence or applying those recommendations. Okay, now, obviously, if we have a recommendation based on the best evidence, okay, that is truly evidence based, we have to take that and apply that to a patient. And I think it stands to reason, right, that we will not be able to apply evidence based practice to all patients in the same way. Okay, so in utilizing the concept of patient centered care, we have to keep in mind that every patient will come to us with patient values and preferences that are different than the patient before them, and that might be different from our own. right? Also, obviously, we have sociocultural values that are different, and also economic circumstances that may make some treatments or some therapies simply unaccessible, right, to patients. So, for example, right, there's obviously emerging evidence and even anecdotal data clinically that the use of a continuous glucose monitor, right, for patients with diabetes can actually lower um, A1C, hemoglobin A1C, which is a measure of glycemic control, okay, by 20%. Okay, which is awesome. That's fantastic. But what if we have a patient that comes from a low from a low a community of low socioeconomic status, and the average cost for utilization of a CGM or a continuous glucose monitor is almost $350 a month, right? Do you think that a patient would be able to utilize that recommendation effectively uh, in their own life? Yes or no? Oops, sorry, guys. Any thoughts? And if you need me to repeat the question and or phrase it differently, please let me know. So, right, I think it makes sense that ultimately for a patient of low socioeconomic status, right, utilizing an expensive treatment, particularly one that's not covered by insurance, okay, could be obviously out of reach, right, for that patient, right? So it's possible that even though, use of a CGM can be highly valuable, right, in the management of diabetes, right, that may not be something that's readily accessible to most patients. Okay. Another example, okay, particularly when we talk about sociocultural values. I used to work in an orthopedic clinic, and very often we saw, patients with ACL ruptures and had to have surgery discussions with them. We had a lot of contact and interaction with the Somali Muslim community in Minneapolis, St. Paul, right? And one thing that often came up in having discussions about surgery planning in this population, many times, right? Our patients from that community often had to have conversations with an imam or a religious leader, right, about the appropriateness of utilizing metal implants inside of the knee, right. And so very often we had to have discussions about either utilization of different implants and or different types of hardware, okay, inside of the knee to accommodate those values and preferences, right? So those are a couple of examples of patient-centered care, right? And how evidence-based practice can actually play into patient-centered care and how that actually affects decisions, right? Does that make sense? And if not, let me know. And as we continue to go through this, excuse me, I will do my best to, excuse me, further clarify that and hopefully make that make sense um, in a better way. Okay, so guys, so obviously as we continue to evaluate, obviously the best possible evidence, right? Clearly, not all evidence is created equal, right? So evidence can have differing levels of rigor. We're going to talk more about that next week. Okay, from systematic reviews and meta-analyses to expert opinion. So the concept of evidence-based practice, or EBP, right, as we abbreviate it, okay, that's going to usually de-emphasizes, right, expert opinion and defining the best evidence in favor, right, of large structured studies, right? So while it's true, right, while it's true that as an experienced clinician, I can rely on my experience, and I should, right, in some situations, that's not the whole of the picture, right? So it would be potentially irresponsible of me to make patient recommendations based on my experience alone without utilizing the evidence. Okay. So our studies often that we use that have the highest level of rigor, right? And we'll talk a lot about what rigor means, in the coming days, are often our systematic reviews and our meta-analyses. Okay. So these are essentially studies of studies where we take all of the studies that have been done, okay, on a specific problem or topic, and we analyze all of them together. Okay, and we are very specific about those studies that we include, using very specific inclusion and exclusion criteria, right? And we attempt to essentially come up with a conclusion, okay, of what the evidence says based on analysis of multiple studies. Okay, that's a systematic review. That's how systematic reviews and meta-analyses are used. Okay, now obviously the reason why having studies with high levels of rigor, why that's really important, is because in doing so, and we're going to talk about this in kind of the next section of the class, right, that minimizes the impact of any extraneous variables, right, on the outcome. Okay, so that gives me a lot more certainty that truly what I am testing, my independent variable, is truly what is affecting or what is changing my outcome, right? As opposed to, extraneous factors. Okay. So let's say, for example, okay, I'll give you an example. Let's say that I want to study the effects, okay, of exercise, okay, the effects of exercise on diabetes, okay, on glycemic control. And so as a part of my study, I recruit 500 diabetic adults from the ages of 18 to 40 years of age, right? And we prescribe them an exercise program, and we tell them that we want them to exercise for at least 30 minutes a day, 5 days a week. Okay, so that we can meet the USPTF guidelines, and we want to essentially follow the effect of that daily exercise program on their glycemic control. We want to see how that lowers their hemoglobin A1C over the next 3 months. Okay, now what are some problems? What are some possible problems with me studying, 500 diabetic patients and, testing the effect of exercise on hemoglobin A1C? What could be a problem with that design? What could complicate that study?
Different types of medications.
Okay, different types of medications. Great, like it. What else? There's one really big factor with diabetes, right? That and it comes down to the diagnosis that can also impact the results of this study. What do you think that would be?
The type.
Yes, 1000%. Wonderful response. Absolutely yes. Okay, beautiful. What we know about diabetes, right, whether type 1 or type 2, is that those individuals, right, with type 1 diabetes do not produce insulin, right? So if someone does have type 1 diabetes, right, it is very likely that by and large that exercise may have less of an effect on their diabetes than someone who is type 2. Okay, the reason for that is this: that people with type 1 diabetes generally have higher baseline random glucose and higher baseline hemoglobin A1C in many cases, right? Particularly also if they're on insulin, and also obviously utilization of insulin can impact that as well, right? So ultimately, in people that are type 1, okay, higher levels of hemoglobin or higher hemoglobin A1C levels, excuse me, and higher levels of baseline hyperglycemia, along with the use of insulin in type 1 diabetes, can actually have an impact on my study. Does that make sense? And if it makes sense, tell me how it makes sense to you. because I want to make sure that this point is getting across.
It makes sense to me because then you'd be like eliminating a confounding factor that might like have a change in your results and make you think like, oh, like there is a positive or there is a negative when really it's just like a different thing affecting the results.
Crushed it. Yep. Great. Amazing. Yes. And that is called a confounding factor, right? Very good. Nice job. Okay. You guys got it. Okay. So here's the deal. Okay. So we know, okay, that studies that have obviously uh, large populations, okay, are often have higher levels of evidence, right? So we have studies that are performed on larger populations that are representative, right? Usually these studies with higher populations are going to be more representative of the population as a whole, right? So in the case of our diabetes study that we just mentioned, okay, if I have, let's say now I want to study 1,000 people from the ages, we'll even narrow it down, we're going to say the ages of 18 to we'll say 18 to 25 with type 2 diabetes, okay, 1,000 people, I can have a lot more confidence that my specific age range and my high population will be much more representative of a similar population in the broader world, right? In the broader population, right? So the larger the population and the more specific the criteria, I can have much more faith that that will be representative of the population as a whole, right? And so that is a general rule of thumb. Okay. Whereas obviously studies with smaller populations, while it's true that, uh, and that kind of got cut off, I apologize. Obviously studies with smaller populations and broader criteria, generally speaking, these are lower levels of evidence, right? And we'll talk more about that obviously next week. Okay. So here's the deal, guys. So when we talk about, um, different levels of evidence, okay, at the very bottom, so if we look at this pyramid, okay, at the very bottom, we have the lowest levels of evidence, right? So it's clinical observation, expert opinion, and case study. All right. So clinical observation. This is obviously what I see with a patient from day to day. Sorry if my dog starts barking. My good, quiet. Okay. So clinical observation, obviously expert opinion. So for example, okay, me saying, for example, that in my career, I've managed over 1,000 concussions. Okay. All right. Even though that's true, right? That would still be considered expert opinion in my case, right? And would be something that I would consider a lower level of evidence, right? So and then obviously a case study. Uh, who can tell me what a case study is? What is a case study? Does anybody know what that is? Okay, so obviously, right, a case study is simply where I detail, the findings of a single case for a single patient that I see, maybe someone that has a rare condition, right, in a paper. Okay. And so I essentially write that case up and I publish it, right? A case series, on the other hand, okay, while still a lower level of evidence, this might be the case of patients that, all have the same condition. And I'm studying maybe 10 or 20 patients that all have the same condition. Okay. So obviously cohort studies, these are observational studies where we simply follow a group or cohort of patients um, generally with a condition of interest or they meet certain criteria in the natural environment, right, without controlling variables, right? So then obviously our randomized controlled trials, okay, those are clinical studies where we essentially have very specific criteria for inclusion and exclusion. And then we have our systematic reviews and meta-analyses. Okay, like we said before, these really represent kind of the highest level of evidence, right? So ultimately, these are studies of studies. Okay, and for most of us, as clinicians, we will end up using clinical practice guidelines to inform our practice. Sorry for the mismatch on the font there; it's a little big. Um, but we're going to end up using clinical practice guidelines, right? And those clinical practice guidelines very, very often are formulated from systematic reviews and meta-analyses, right? And or right randomized controlled trials. So we have these very large these higher levels of evidence that generally inform clinical practice guidelines. So here's an example of this. Okay, geez, that's really, really large. Sorry if that's hard to read. Okay, so ultimately these are guidelines from the American Diabetes Association, right, on management of diabetes in people with chronic kidney disease. Okay, so what are recommendations, right, for screening, right, um, and testing. So obviously, based on the recommendations, okay, from the studies included here, they came up essentially with these clinical guidelines. So they say here that in people with type 1 diabetes, that people with type 1 diabetes should have, okay, kidney labs, okay, to screen for CKD every 5 years. I'm sorry, yearly after 5 years, 5 years after diagnosis, right? And then people with type 2 should obviously have should have labs drawn every single year, right, for CKD. So EGFR, right, and urinalysis, and creatinine as well, right? So how do we screen it, right? They're going to say, obviously urinalysis, and then also, GFR. So we're going to look at their kidney labs, right? So let's say that you know that that we're suspicious of CKD, right? So ultimately, um, they have a GFR below 60, right, which is going to be indicative, right, of altered kidney function. Maybe they have uh, high creatinine as well, right? So they give us guidelines here for what exactly signifies chronic kidney disease in patients with diabetes. Okay, so this is an example of a clinical practice guideline that's based on high levels of evidence. Okay, okay. So it is very often the case, right, that while it's true that lower levels of evidence, okay, studies that are not systematic reviews and meta-analyses, it is true that we can still utilize these, right? We're not going to be able to utilize them to the same level um, as a systematic review and meta-analysis, but they can still provide useful information. Okay, and it very well could be that maybe your condition of interest or the problem that you're looking to essentially study, right, is not a problem that has been readily studied within the broader scientific community, and so there may not be very many, pardon me, clinical practice guidelines, systematic reviews, or meta-analyses published on that topic. Okay, however, you could have, right, studies that have been published, large cohort studies or large randomized clinical trials, randomized controlled trials, right, with large sample sizes that can be reflective of the population as a whole, right? Um, and it's really important, right, that if you have that if you are utilizing a study, right, that maybe is not coming from a systematic review or a meta-analysis, that study should be replicable. Okay, and we talked a little bit about this on maybe like the first or second day of class. We used our example of patients with knee replacement, and giving them ibuprofen postoperatively to control pain levels. Okay, when I say that a study should be replicable, what do you think I mean when I say that a study should be replicable? What does that even mean?
Another researcher should be able to do your study and get similar or the same results.
Yep. So yeah, exactly. So a researcher should be able to take your study, utilize the exact same methodology, and reproduce similar results, right? And like we talked about, the more reproducible that a study is, right, the higher our confidence can be that we can trust those results, right? Um, so obviously, if we're with a patient and we're attempting to talk about, what the evidence says, right, despite the fact that there are no systematic reviews or meta-analyses on a topic, right, it's really important for us to clearly communicate with the patient that while it's true, right, that high levels of evidence are not readily available, here's what the studies are saying, and here's how that might apply to the patient, right, uh, in real life, right, in clinical practice. So, guys, as we obviously kind of continue to move forward here, right? Not every problem that we see in clinical practice is going to lead itself, okay, to a true um, experimental study, right? We're going to spend a lot of our time talking about experimental studies here in the next few weeks, but not everything that we're going to be discussing in class, right, will be obviously based on experimental studies. You know, in the world of epidemiology, okay, where we're interested in establishing uh, injury rates, okay, things like prevalence, what percentage of people within a given population have a disease or condition of interest um, at one point in time, right? Or how often, if we're looking at rates of maybe concussion, maybe rates of um, we can say even rates of polytrauma after car accident due to not wearing a seatbelt, those types of things, right? um, those are all kind of fall under the umbrella of quasi experimental or observational designs. Okay, so when we talk about something obviously like qualitative research, okay, qualitative research really has to do, and we're going to spend some time on this later in the semester, but this really has to do with understanding the lived experience, right? Or the, ideas or conception that a patient has around a specific topic or concern. Okay, for example, I saw this a random article the other day. When you open up your web browser on the internet and you see in these random stories, like news stories, but there was a family that had moved, right, from a large metro area to kind of like the mountains of West Virginia. And they essentially said, right, that their access to healthcare within that area of the country was so bad that they actually had to leave their new home and move back to where they came from just so that they could just so that they could access healthcare, right? So understanding these broader problems like how people experience or how people are impacted by a lack of access to healthcare. Maybe it's uh, experiences that people have had within, doctors' offices or with healthcare providers that maybe prompt them to either withhold information from a provider and or uh, you know other types of experiences. Right? Those are things that those thoughts, ideas, feelings can't necessarily be measured right in an experimental study, but obviously we can utilize that type of data and still develop data from that, right? Okay, and then obviously finally quality improvement, which we'll talk more about as well later on in the semester, right? Quality improvement is also an equally valid form of inquiry or research, right? And many of you, this is something that you guys are going to see all the time, right? Particularly if you're working in larger settings, or even in clinics where maybe you have larger patient loads, and maybe some of your managers or administrators in those settings may be concerned with how much time a provider spends in a room and or patient satisfaction, right? And so you may be charged as a part of a team in coming up with a quality improvement process, right, to obviously increase patient satisfaction within your practice setting or within your job, right? So that's an example of quality improvement. And so all of these are different study types that we'll talk about and utilize throughout the semester. But once again, right, not every type of evidence that we're going to come across is going to lend itself to an experimental model like we've been talking about thus far. Okay, so clearly, right, as we talked about, not everything is going to fit, right, with the traditional research process. We talked about obviously qualitative studies, right? If we want to understand lived experiences, or a condition where evidence is lacking. Okay, that's another area where qualitative studies can be really, really useful because they can help us define, right, a principle and or a problem that we don't fully understand. And then when we finally have enough information about what a problem consists of, then we can actually start studying that problem quantitatively, because now we know, right? We have we have definitions, right, of what that problem comprises. And then obviously quality improvement, right? So there we use obviously an established cycle, the PDSA cycle, Plan, Do, Study, Act, right? And our focus there, right, is to make system level changes in a healthcare system, or in our setting, based on observed problems, and trying to propose solutions based on that Plan, Do, Study, Act cycle. Okay, so um, in all of these guys, in all of these different types of research, right? What we find and the evidence that we collect and find, right, with these different processes, that is all okay. It's all evidence in some degree. Okay, while there may be less rigor, right, in evidence that is obviously collected, in a qualitative nature and or an observational study, it's still evidence, right? So higher levels of evidence may not be readily available, but that doesn't automatically discredit, right, lower levels of evidence when they exist. Okay, so hey guys, that is we'll get more into this obviously next week, but that was kind of an introduction, right, to evidence-based practice. um and as we kind of start, and I'm going to minimize this and uh, kind of go back to our little room here, but as we wrap up, guys, how many of you have started to kind of think about your research questions? How many of you kind of have an idea of what you might want to start looking at?
I was just wondering, is there like a list of guidelines or like kind of ways to get started to think about questions? Because I really like have no idea what to look into.
Okay. Yeah, that's a great question. So we will actually next week, we're actually going to spend two whole class periods actually kind of working through all of that and kind of helping you guys formulate your questions, right? So we're actually going to spend some time in class together, working on those, kind of determining like what those questions should be, right? And kind of looking at guidelines, right, for kind of developing those questions, use of PICO and all of those types of things. So yes, to answer your question, Emily, that is something that we will spend time doing, right? Kind of both formally, right, but then also obviously in class, kind of working together one-on-one to come up with those questions. So, okay. Any other questions, guys? Okay. Well, guys, have a great weekend. Hope that you guys have a good, safe weekend, and I will see all of you on Monday. Okay. If you need anything, let me know, and I will see you guys in Matson. Okay.
Thank you.
Take care, guys.
And then, Professor, I had a quick
Yep.
question. Yep. So the research questions or your research topic,
Yeah.
does that have anything to relate back with the city?
So that's actually the city. The city training is actually a part of the methodology section of this class, and
Okay.
that's not gonna be due until I believe October, November. So you still have time on that. So
Okay.
when we
I'm
talk
not
about
logged into that though. Like I missed the first Did I miss class? Yeah, I missed class one of the days, and then I wasn't sure if we registered for city or like we talked about it briefly on Wednesday, but last Friday I wasn't there.
Right. So, uh, so the city training is not something that we've actually discussed in depth yet, right?
Okay.
So that is so how that works though, Carson, is when it's time for you guys to complete that, okay, you'll have a link that will be posted, and literally what that consists of is you click into that, right, and that involves working through a series of modules, okay, and then when you complete those modules, then you get a certificate, right, stating that you've completed that training, and that is what you will turn in.
Okay.
It's honestly really simple. All it is you going in and clicking through modules, right? And then once you've completed those modules, you then turn in that certificate to me, and that's it. You've completed the training.
Gotcha. Okay. So, and then there was a few other things. There was like uh, introduction and lit review draft.
Yep.
Was that, when did that get assigned? Like it said like, or like I'm looking at it, it's like it's overdue by like 9 days, 8
Okay.
days.
So Carson, what you're looking at on Moodle, okay?
Yeah.
When I posted that, okay, but if you look at the syllabus, that introduction and lit review is actually it's not due on the syllabus until
Until the
October.
13th of October.
That's correct. So
Okay.
if you see those dates on Moodle, don't freak out. And I will actually talk in class about that on Monday. So
Okay.
what I'll do, I appreciate you bringing that to my attention. What I'll do is I will go in and I'll change those dates on Moodle, because now I know what you're talking about. I know exactly what you're saying to me. What you're telling me and is that the dates on Moodle do not correspond with the syllabus.
Yeah,
I
because
see
like
what
a
you're
few,
yeah, I see what you're saying.
yeah, because like I've been trying to catch up a little bit, and like
No
my
worries.
entire feed has been just overdue with assignments, and now like I missed the Wednesday's quiz, and that's on me. But
Okay. No,
but yeah, I was just trying to go through a few different things, and I was like,
okay. No, I
yeah,
do see what you're saying. So the
okay,
bottom line, don't freak out. It's not overdue. Okay, it is not
gotcha,
overdue. So I will make those changes on Moodle, right? And I will change those dates so that you guys don't think that you're behind, because I assure
okay.
you are not behind.
And
Okay.
then what's this research topic? Was that like when I missed the first few on Wednesday? Were we supposed to pick a research topic? And
No, so you don't have a topic due yet. That's so let me hang on, Carson. I'm pulling up the Moodle page right now. Take a look at the do. Okay, so ultimately, right, let me go to the syllabus. Okay, so so the first and foremost, right? When you turn in those first three references for your question, so we're going to actually Monday and Wednesday in class, okay, we're going to spend time, right, talking about your research questions, helping you formulate those questions, and then, okay, you can see on the 27th of September, you have your first three references due, okay,
yep,
and there will be essentially a document where you will essentially give me a draft of your question. It doesn't have to be the final question, just a draft, right? What are you
gotcha.
thinking about doing, right? With the first three references for that question. Does that make
All right.
sense?
Nope. Yep, that makes sense, and I'm
So
sure we'll talk about it more
yep,
throughout when it gets up closer and on Monday too.
yep. So hopefully that helps kind of mitigate the confusion. Does it? Does that help?
Yes, that does help. It's just a
Okay.
few of them were just overdue, and I'm
Nope. Very good. So
yeah,
yeah, and those were middle dates, and so I will fix that. So yeah, please don't worry about that, and I will fix that on Moodle. So no problem. Okay.
gotcha. Yep. Sorry for taking up most of your time.
No, that's okay, Carson. I appreciate your questions, and it's honestly, it's questions like that 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 help, because if I don't know that you guys are getting, maybe a notification stating that something's overdue, right? Then I can't fix it, right? So thank you for asking me that. So don't feel bad about that at all. Okay.
All right.
Okay.
Well, take care.
Okay. Have a
Have a
good
nice
day.
weekend.
All right. You too.